হ্যাঁ, হ্যাঁ, শুরু করছে দেখো সামটুকু ছবি। ওকে, আমরা কোনো কথা কওয়া শুরু করছি না, ওপেন করে বই রয়েছে। ওকে, স্টার্ট করে দেখো। হুম, ওকে, হুম, না, ওকে। হুম, বুঝলে? আচ্ছা, আমি বুঝলাম। ওকে, থ্যাংক ইউ। Good morning, student. Hope all of you are okay and fine. Today, I am I am going to discuss about short cases, usually very common in your examination purpose. There are few short cases important to you like cataract, dacrocystasis, chalazion, and pterygium. Among four, cataract is very important. Cataract, you know, this chapter of cataract nicely discussed in your lecture class. Our respected teacher, Professor Mushai Thakur, sir, was discussed in your lecture class. Just this is today class is review as well as discussion of short case of cataract. These pictures of cataract. This is a mature cataract, opacity of the lens or its capsule. You know, little bit anatomy of the lens. This is the biconvex structure, avascular, colorless, and transparent. The lens is divided into nucleus and cortex. It covered by capsule. Just simply about anatomy of the lens. And some examiners sometimes choice asks to what are the disease of lens. You know, cataract is the common disease of lens, but some examiner choice what are the disease of lens. When examiner asks to what are the disease of lens, first you say there are congenital, there are acquired. Under congenital, aphakia, coloboma of the lens, microspherophakia, lenticonus, and congenital cataract. And acquired cataract and aphakia. Aphakia, everybody you know, aphakia means there is a absence of lens. This is the case related discussion. So in your exam, at least two cases have to face. Suppose case is cataract. When in your examination hall, teacher asks to you, what is your diagnosis and what are the cases have you seen? Sir, I have seen two cases. First case is age-related mature cataract in right eye. Or if your case is immature, then you say age-related immature cataract in right eye. Examiner asks to you, what is your diagnosis? Answer, according to maturity of the cataract, you say either age-related mature cataract in right eye and age-related immature cataract in right eye. Then some examiner may be asked to why you say in right eye. In means this is a disease of inside the eye. That means disease of in inside the eye. In this way, you say this is you say in right eye. Lens is the intraocular structure, so this is the answer is in right eye. Okay. Then there another question may arise. What are your case may be mature or immature? What are the findings of mature cataract? What are the findings of immature cataract? Later on, I discuss. Then examiner may ask to you, what is your treatment plan? Your case is mature or immature. What about your treatment plan? Treatment plan is extracapsular cataract extraction with posterior chamber intraocular lens implantation. We remember maximum students are mistake during examination. Extracapsular cataract extraction. Somebody say extracellular. There is a mistake. There is extracellular. Nobody try to remember. No say cellular. This is the extracapsular cataract extraction with posterior chamber intraocular lens. Posterior chamber, why you say? Usually lens is situated in the posterior chamber. So answer is with posterior chamber intraocular lens implantation. Never you say IOL. Better to say intraocular lens implantation. And there may be another question, complication of anterior chamber IOL. Later on I discuss. So what is your diagnosis and why in right eye and and what is your treatment plan? Some examiner choice you say your IOL is implanted in capsular bag or in posterior chamber. You should clearly identify clearly conceptions. You know what are the space of posterior chamber. Posterior chamber space is in between lens, in between iris and post and posterior surface of the capsule. This is the space of posterior chamber. In posterior chamber, there is a two space where we will implant IOL. Number one space is sulcus. Number second space is capsular bag. But ideal space is capsular bag. This what is capsular bag? During cataract surgery, you know, after capsulorhexis, we remove the anterior postern option of anterior capsule and leaving behind the peripheral part of the anterior capsule and intact posterior capsule. This is the picture helps to understand what is capsular bag. This is the capsular bag where IOE or surgeon implanted intraocular lens in capsular bag. This is the ideal side of posterior chamber. So question, what is question? If examiner asks to you, you say your IOL is implanted in posterior chamber. So posterior chamber in which side? There is a two common side in posterior chamber. One is sulcus, one is capsular bag. But better option is capsular bag. Usually every surgeon try to IOL implanted in the capsular bag. And another, so I think you clearly understand what is capsular bag. And another space is sulcus. Sulcus is the space in between posterior surface of the iris and an anterior surface of the anterior capsule. Again, I say, what are the space of sulcus? Space of sulcus is in between posterior surface of the iris and anterior surface of the anterior capsule of lens. Here, IOL is implanted at the sulcus. So, it is a second option is IOL implanted, but better action is capsular bag. So, I think clearly understand what is capsular bag, what is sulcus. In posterior chamber, there is a two side capsular bag and in sulcus, but ideal side is capsular bag. And again, picture understand to you, this is the capsular bag. IOL is implanted in bag. Sulcus in space between posterior chamber of space between iris and anterior surface of the lens. And some examiner, especially if your answer is confident, then examiner I think maybe this student is good enough. So examiner is satisfied to you, then asks to you, okay, you said IOL is implanted is capsular bag. This is the ideal size. Why? And what are the advantages of intraocular lens in capsular bag? Then this is the answer. IOL is closer to nodal point of the original crystalline lens, resulting better image resolution. Number two, proper anatomical side. Number three, low incidence of lens decentration and dislocation. That means if you IOL implanted in capsular bags, there is no chance of dislocation of intraocular lens. So this is the most benefit if you implanted in capsular bag. And reduced posterior capsular opacification. If you will I will implant in capsular bag, there is a less chance of PC or posterior capsular opacification. And less uveitis. Uveitis, there is a very minimum chance to uveitis. You know, postoperative uveitis is common complications of cataract surgery, but if you implanted in capsular bag, then uveitis chance is less. This is the benefit of IOL implant in capsular bag. And there is another question in exam. If will you fail to implant IOL during cataract surgery? This is the question of examiner. During cataract surgery, usually I or any surgeon I will implant it. This is the this is a common situation. But anyhow, if IOL is failed, surgeon is failed to implant it, this condition is known as aphakia. Another definition of aphakia, absence of lens is aphakia. So during cataract surgery, surgeon remove the normal lens, whatever is opacification lens, then surgeon failed to implant the IOL. This condition is aphakia. But if surgeon implanted IOL, that is known as pseudophakia. In this way, when examiner asks to you what is aphakia, same time another question arises: what is pseudophakia? Pseudophakia. What is pseudophakia? When cataractous lens replaced by artificial intraocular lens, condition is pseudophakia. Another question to you: suppose after cataract surgery, visual acuity is 6 by 6. That means 100% normal, 100% vision. If need any spectacle of that patient, before suppose there is a of scenario of patient. Suppose patients before cataract surgery vision was hand movement. There is a vision is very poor. When surgeon nicely cataract surgery done and vision is 6 by 6. Before cataract surgery, hand movement. After cataract surgery, 6 by 6. That means 100% vision. Question: if need any spectacle of that patient, answer. What is the answer? If IOL is accommodative IOL or multifocal IOL, usually no need of any spectacle. But where the common surgeon, usually implanted as a unifocal IOL. Usually we implanted unifocal IOL. Unifocal IOL is only helps in distance vision. So vision is 6 by 6, but if here there is a some difficulties in near vision. Why near vision difficult? Because here accommodation is disturbed. Accommodation is disturbed. So for accommodation purpose, for near vision, we give some spectacle to patient about plus 2.5 diopter or plus 3 diopter. So if examiner asks to you before cataract surgery hand movement, after cataract surgery, if vision is 6 by, if need spectacle, sir, spectacle is needed for near vision. That is plus 3 or plus 2.5 diopter. Again examiner asks to if you use multifocal or According to IOL, if need any spectacle, usually no need. Usually, of course, this word should end usually. Why usually? Because although some patient will give multifocal according to IOL, little bit power is needed. So must you say usually in case of accommodative and multifocal IOL. And there is a question arise: what is accommodation? You know what is optical adjustment of eye to see near object clearly. And what is the total loss of accommodation? Total loss of accommodations are, you know, atropine. The drug is important: atropine, aphakia, and pseudophakia. These are three important conditions where accommodation are totally lost. And types of IOL, better to you collected from your lecture class. And these are pictures of intraocular lens. It is also important in case of OSPE exam and Viva exam. In Viva process, some examiner there is a picture show to you what is this. Then you say this is the artificial intraocular lens. And what are the parts? Parts is optic part and haptic part. Then examiner may say to you what is the function of optic part, what is the function of haptic part. And some examiner asks to you, your patients is cataract and patients will see after cataract surgery. How will we assess? Answer is retinal function test. These are perception of light, projection of ray, pupil reaction, color vision, a Meadows road test, and 2-point light discrimination test. Everything discussed in your lecture class. Among perception of light and projection of ray, among two, which is very important is perception of light. Because if any patients, if there is a no perception of light after cataract surgery, there is a no vision. Pupillary reaction very important. If people after reaction, we assess the pupillary reaction, we assess what about the status of optic nerve and retina. If there is a disturbance, if there is any optic nerve difficulties, we idea from pupillary reaction, and we may say to patient, maybe you will not see after cataract surgery. And color vision also it helps to status of optic nerve and retina. Meadows rod also helps to guide what are the status of macular function, especially macular function. Sometimes a patients of macular hole, macular edema, is this Meadows rods guide to us whatever status of macula. If macula is disturbed after cataract surgery, patients has no satisfactory vision. It's very important. Suppose a patients usually before cataract surgery vision is poor, of course he has right after surgery he deserve vision will be improved. But if not improved, or if you say previously there may be some distance, maybe you see or maybe you not. So it is it is safety, it is safe guideline to surgeon. And this is again parts of IOL. And there is some picture of anterior chamber IOL. Just before picture, there is a some design change of haptic, and this is a ACIOL design change. There is a little bit change. I think you understand. This is the simple picture of IOL, and this is the special designs of anterior chamber IOL. This haptic is special design. So when I implanted in anterior chamber, there is a chance to friction or rubbing on iris cornea. So this is special. This is a design. Why the design? There, if you implant an as this IOL, there may be dropout of IOL. So this design helps to no dropout of IOL. Dropout means no goes to in vitreous. For this why this special design, but this is the benefit to drop out of, but another disadvantage is continuous rubbing in iris. So if continuous anterior chamber of IOL is rubbing in iris, there is a chance to uveitis, glaucoma, hyphema. So there is a advantage is fixed position in IOL and no chance to no go to vitreous, that means drop out, and another disadvantage of anterior chamber IOL. And this is the findings of immature cataract. In case of immature, visual acuity reduced to counting finger, color of lens grayish white, iris shadow present, and fundal glow present. Fundal glow usually will see by special instrument known as ophthalmoscopy. This is the question. Examiner asks you for fundoscopy examination what type of instrument need. Your answer is ophthalmoscope. And in case of mature cataract, visual acuity reduced to hand movement or perception of light, and color of lens is pearly white, iris shadow absent, and fundal glow is absent. Here there is the important question: color of lens is in case of immature, sorry, iris shadow is present and iris shadow is absent. Now question is, what is iris shadow? This is the features of pictures of immature and mature. This is the mature is pearly white. This is the grayish white. There is a some here, and near the iris there is a iris shadow, crescentic shadow. Here there is a iris shadow absent. And what is iris shadow? This is the black crescent shadow of iris which falls upon the opacity of lens due to some part of lens is opaque and some part of lens is transparent is called the iris shadow. It is common sign in immature senile cataract. I repeat the answer. What is iris shadow? This is a black crescentic shadow of iris which falls upon the opacity of lens due to some part of the lens is opaque and some part of the lens is transparent. It's called the iris shadow, a common sign in immature senile cataract. This is the picture. This is a picture helps to understand what is iris shadow. This is the black shadow. This is the black shadow. This is the iris shadow. I think clearly understand. And again, I show to you. This is the crescentic shadow. This is the iris shadow. Here there is the absence of iris shadow. So very important findings of immature cataract, iris shadow is present, and in case of mature cataract, iris shadow is absent. And what are the symptoms of cataract? You know, painless progressive visual loss. Maybe you found glare, myopic shift, and monocular diplopia. Myopic shift, I like to say something about this. Usually, when what is myopic shift, what is second sight? Very important. Some examiner asks to you, what is this? Then you should clearly understand. Usually age-related mature cataract, that means this is the senile cataract, that means usually occurs in elderly person. You know, for when a patient go to 40 years for near vision disturb, known as presbyopia, and on that situation at the age of 40 years, we prescribe a glass plus 1 power. When patients go to 45 years, then we prescribe 1 point plus 1.5 diopter. When patient go to plus at the age of 50 years, then we increase the power about plus 2. When go to patients about 55 years, then we prescribe plus 2.5 diopter. You thinking that a patient when when age was 40 years start the glass, then 55 years increasing continuous glass power is increasing. At 15 years without glass, impossible to near vision. When patients develop immature cataract, like at the age of 60 years or 58 years, patients develop immature cataract and myopic shift develop. So here patients develop minus power. Suppose that patients need for myopic shift for distance vision need minus 0.25 diopter. So near that patient need plus 2 point diopter, but distance minus 2.5 diopter. Algebraic solution is for near vision is 0. Then patients feel euphoric. Up to from 40 to 60 years, she needs spectacle for near vision. When patient develop immature cataract and myopic shift occurs and no need of any spectacle for near vision, then patient develop euphoric. In this way, this is the second side. I think you understand what is second side. And there is another question. What are the causes of gradual loss of vision? You know, one cause is age-related cataract, other cause is uncorrected refractive error, primary open-angle glaucoma, age-related macular degeneration, and diabetic retinopathy. Among five, another question arises: what are the irreversible loss of vision? What are the reversible loss of vision? In case of age-related cataract, if you cataract surgery, there if you do cataract surgery, vision is improved. This is the irreversible loss of vision. And refractive error, you will correct the refractive error, then vision will improve. But primary open angle glaucoma, age related macular degeneration, diabetes, this is the irreversible loss of vision. Why will you treatment on that case? For prevent the further loss of vision, and also there is some treatment to helps to deterioration, helps to no deterioration of vision. And what are the risk factor of cataract development? I think you know, cigarette smoking, who are use of steroid long term, sunlight, especially farmer who are exposed to maximally sunlight exposed, diabetes mellitus, obesity, and there may be trauma. And this is the risk factor of cataract development. There is some causes of congenital cataract. You know everything. Just simply you say hereditary, idiopathic, and torch infection. This is important. In this way, this is the slide presented to you. Toxoplasmosis, torch infection. We commonly, invariably question to students, what are the causes of congenital cataract? If any student say intraocular infection, torch infection, then our next question to student, what do you mean of torch means? What are the organisms deals? Answer is toxoplasmosis, toxoplasmosis, toxoplasmosis. R for R rubella, C for cytomegalovirus, H for herpes simplex. And there are other causes of congenital cataract and metabolic disorder like galactosemia, hypoglycemia, etc. And acquired cataract, you know, senile cataract, presenile cataract, traumatic cataract, complicated cataract, and electric radiation, and there is a drug. Very important. There are two important things. One is complicated cataract, another is toxic cataract. A maximum examiner choice. What do you mean by complicated cataract? Answer is complicated cataract is the cataract due to some intraocular disease. As for example, chronic uveitis. You must say chronic uveitis. There is some student say acute uveitis. No, chronic uveitis. Pathological myopia, glaucoma, specifically glaucoma. When say glaucoma, there is another question. In glaucoma, there is a cataract developed. This is the particular name of cataract is glaucomflecken. Again, I particularly in glaucoma, there is a special type of cataract developed. Name is glaucomflecken, and retinal detachment and retinal pigmentation. This is the causes of complicated cataract. Toxic cataract, there is some drug induced. Common is corticosteroid, chlorpromazine, busulfan, and imidazole. Gold. This topics is nicely delivered by Professor Moshe Thakur sir, you again collected or again better to again review from our sir class. And this slide especially for extraordinary student, some when examiner understand this student is brilliant, this student is studious, then this like of question usually delivered to student. In case of there is some systemic disease, and systemic disease causes some cataract. And what are the particular name of this cataract regarding in systemic disease? Like in diabetic mellitus develop cataract, this is the particular name is snowflake cataract. So examiner try to some examiner uh, may ask to you in case of cataract, in case of diabetic mellitus, there is a cataract developed. What is the name of that cataract? Snowflake cataract. In Wilson disease, you know, develop cataract. Particular name is sunflower cataract. And myotonic dystrophy, there is maybe cataract develop. This name is Christmas tree cataract. And neurofibromatosis, disease of neurofibromatosis develop cataract. Name is especially shield cataract also. Shield cataract. The next slide, there is some picture have to understand. This is the snowflake, especially developing diabetes mellitus, and sunflower cataract developed in Wilson disease, and Christmas cataract developed in myotonic dystrophy and shield-like cataract neurofibromatosis. This is the pictures, and you thinking there is a particular name of cataract regarding in respect of some systemic disease. And there is another cataract, rosette shaped cataract. Usually this is the after blunt trauma developed cataract. And there is some morphological classification: subcapsular, nuclear, cortical, polar. And it is also discussed in your lecture class. And just there is a picture, understand to uh, what is morphological classification. You know, this is the capsule, or behind the capsule there is a subcapsular. So this is the subcapsular cataract, and here this is a polar cataract. There may be posterior polar cataract, there may be anterior polar cataract, and this is the cortical cataract. There is a especially when only cortex is opacified. There is the cortical cataract. There is a nuclear cataract. So you thinking according to histology anatomy, capsule, cortex, and nucleus. Capsule related to posterior subcapsular, cortex related to cortical cataract, and nucleus related to nuclear cataract. Another option is anterior polar and posterior polar. I think clearly understand and you clearly remember what is the morphology classification of cataract. And according to maturity of cataract, you should know lamellar separation, incipient, immature, mature, and hypermature. There is important cataract is Morganian cataract. Some examiner asks to you what do you mean by Morganian cataract? Usually, it is the actually this is one of the patterns of hypermature cataract. What is Morganian cataract? When total cortex is liquefied and it looks like milky white. After that, when cortex is totally liquefied, nucleus is settles at the bottom, like sinking a lens nucleus inferiorly within the capsule. You know, in center there is a nucleus of the lens. When cortex is liquefied, nucleus settle down in the bottom. This is the Morganian cataract. So this is the very important. If any patients develop in case of hypermature cataract, Morganian cataract develop, there may be patients develops too much pain. On that situation, emergency condition, and you should as early as possible early cataract surgery you should done. So sometimes examiner say to you, when will you do early cataract surgery? Answer is, in case of hypermature Morganian cataract, need to early cataract surgery. What about vision's output? And complications of cataract. Complications, you clearly you know, and some usually in our chamber, in our hospital, in outpatient department, maximally some patients question to our doctor, even to us. Suppose patients of mature cataract, and doctor advice to patient, you need cataract surgery, but patients fear to surgery. Then you have to write to explain to patient, if you do not do surgery, what complication may develop in future. What are the complications of that? Lens-induced glaucoma. Popular name of lens-induced glaucoma, phacolytic glaucoma, usually occurs in mature cataract, and phacomorphic glaucoma occurs in immature cataract. And there may be subluxation of cataract, there may be dislocation of lens, there may be lens-induced uveitis. And there is another important question some examiner asks to you: what are the non-surgical management of cataract? There is some medication like antioxidant supplement. There is so many antioxidant supplement available in market. Anyone you prescribe vitamin C, vitamin E, beta carotene, and there is some eye drop mydretics. Suppose there is a polar cataract and you give mydretics, there is a pupil is dilated, periphery in polar cataract, periphery is clear. So when it dilated through periphery, patient may see everything. So there is another treatment option is mydriatic, but especially in center cataract. But whole for if there is a cataract in whole area, mydriatic is not helpful. So especially posterior subcapsular cataract or polar cataract, if you dilated, periphery of the lens is clear, so through periphery patient easily see. Now this is another option. And eyeglass, if myopic shift develop in immature cataract, you may prescribe glass, usually minus power lens, but depends on retinoscopy examination. This is a non-surgical management of cataract. And when you do cataract surgery, maybe you discuss in your lecture class, visually handicapped person and glare caused by bright light is problem, have another vision threatening eye disease like diabetic retinopathy and macular degeneration. You just think about, suppose patients of diabetic retinopathy, on that patients need to some retinal laser therapy, but little bit there is a cataract, but patients cataract opacity of lens opacity is not enough, but lasers for laser purpose, on that situation you must at first cataract surgery, then you go for treatment of retina, treatment of diabetes, that means retinal laser and cosmetic purpose. And for the investigation of cataract surgery, you know, before cataract surgery you need to some investigations. So what are the investigations of cataract surgery? Ocular, there may be systemic. Ocular, there may be systemic. Ocular intraocular pressure is very important. Usually by cestonometer and by applanation Goldman tonometer, we measure the intraocular pressure. If intraocular pressure is more, you wait and we prescribe first anti-glaucoma drug. Then after reduction of intraocular pressure, then we will go for surgery. Otherwise, during cataract surgery, there may be some problem created. And conjunctival swab for culture is usually suspected patient. If you uh, during examination, if you guess there is some discharge and watering, on that situation you should done conjunctival swab. Biometry is very important. Biometry is very important. Without what is biometry? By this technique, we calculate the power of the intraocular lens which will be implanted. For biometry purpose, there is a two machine is needed. One is S-scan. Examiner asks to you for biometry what are the machine are needed for this test. One is S-scan, another is calorimeter. Scan, why? For measure the axial length. And keratometer for why? Keratometer for measure the radius of curvature. There is a formula, popular formula is SRK formula. And this is the formula P equal to A minus 2.5 L minus 0.9 K. Some examiner may ask what is the SRK formula. So you should try to remember what is the SRK formula. And there is a calculation form of biometry. You try to understand. A means constant. Usually constant is stable. 118, 100, 118 or 118.4 or 118.2. This is the stable. So our calculation 118 is stable, a constant. 2.5 into L mean axial length by scan. Suppose 23. And keratometer radius of curvature average K reading suppose 43. So by calculation we understand, we uh, solve the solve it. 21.8, that's mean 22. This is the ocular, intraocular pressure, conjunctival swab, and biometry. And systemic inhibition usually commonly RVS ECG, and chest X-ray usually in case of suspected patient. Usually in case of suspected patient. And surgical treatment, intracellular non-surgical treatment, very little bit, and surgical. This is the main treatment of cataract. Intracellular intracapsular cataract extraction and extracapsular cataract extraction. But intracapsular usually you will not done today. Extracapsular is popular, and there is a common varieties conventional. SICS is a very common, and phacosurgery. But it is depends on size of incision. And anesthesia. During cataract surgery, what are the anesthesia usually will given? Usually, most probably we will give local anesthesia like surface or topical anesthesia. Usually, in case of surface anesthesia, we use procaine, xylocaine, etc. Nerve block by a 2% xylocaine or 0.75% bupivacaine. An infiltration technique. There is the infiltration technique is peribulbar block. Retrobulbar is usually will not practice. Peribulbar block we practice commonly. General anesthesia. Usually in case of cataract surgery, either some condition usually no give general anesthesia. What are the condition we will give general anesthesia? Children or infant and uncooperative patient, mentally retarded patient, and patient preference. Some patient preference better to by GA. In this way, we'll give some general anesthesia. And type of local anesthesia. Some examiner asks you what are the types of local anesthesia. In from your pharmacology knowledge, there is a ester group, there is a amide group. There is some examples of amide group, some example of ester group. And there is a common local anesthesia. One is oxybuprocaine. This is the surface anesthetic agent, lignocaine, and bupivacaine. There is some adverse effects of surface anesthetic agent and topical anesthetic agent, epithelial or endothelial toxicity, allergy to drug, and alteration of lacrimation, and surface keratopathy. Surface keratopathy. Peribulbar block usually we will give in peribulbar area. This is the peribulbar block, and injected into peribulbar space, spread to lead and other spaces. And what are the agents we'll use in peribulbar black? Lignocaine and bupivacaine, and along with hyaluronidase. Why you use hyaluronidase? Because it helps to spread the local anesthetic agent. You give one point, but this agent helps to whole compartment of the peribulbar block. So very important in case of hyaluronidase. And steps of SICS, everything, but just anesthesia, incision, sclerocranial tunnel, and defined blue, capsular axis, residual cortex aspiration, and implantation of posterior chamber intraocular lens. There is a pictures helps. This is the video of SHS helps to understand what is the cataract surgery of cataract, especially SICS. First we give superior rectus. This is a radial suture. There is a superior rectus radial suture. It helps to why you give radial suture properly expose the incision area and fix the eyeball. There is a two purpose, and then conjunctival peritomy. Conjunctival peritomy, we just release the conjunctiva of incision area. Incision area here just relieve the. This is the name is conjunctival peritomy. This is the corneoscleral tunnel and tunnel is made by crescent knife. Crescent knife. I think you understand what is this. There is a another important surgery is phacosurgery. You should know about this. What is phacoemulsification? Phacoemulsification is a modern cataract surgery method and in which the eyes.
A cataract is the clouding of the
These
eye's
are the
natural
pictures
lens,
of.
a structure which is
This video
positioned
helps to
behind the cornea,
understand this is a
iris,
phacoemulsification.
and pupil. Like the glass lens of a camera, our lens adjusts to focus our vision. The lens is mostly made up of water and protein. As we age, these proteins change and may begin to clump together, obscuring portions of the lens. To correct this, a doctor may recommend phacoemulsification cataract surgery. Before the procedure, the surgeon numbs the area with anesthesia. Pressure may also be applied to decrease the internal pressure within the eye. This will lower the chances of complications later in the surgery.
Here there is a phacoemulsification. You know, in case of phacoemulsification, only 3.2 millimeter is incision. These instruments helps for capsuloresis. This is the capsuloresis. Just anterior capsule is removed, and there is a special phacoprobe used, and by phacoprobe emulsified and aspirated of nucleus. Then intraocular lens is implanted.
Restores the patient's vision.
So phacoemulsification, what is this? This is a modern cataract surgery in which the eye's internal lens, that means cataract, is emulsified and emulsified with ultrasonic handpiece and aspirated from the eye. Just you thinking, by phacoprobe lens is emulsified and pulverized by ultrasound energy and aspirated. This is the phacoemulsification. So, phacoemulsification is better or SIC is better? Definitely phacoemulsification is better. What are the advantages of phaco? This is a very small incision, short hospitalization, less astigmatism, and less postoperative complication and early rehabilitation. Very important to you. What are the advantages of phaco? Small incision, very small, 3.2 millimeter, short hospitalization, less astigmatism. If you there is a minimum incision in this way, there is a less astigmatism and less postoperative complication and early rehabilitation. Patients go to normal life very quickly. In this way, early rehabilitation. In case of advantages of SICS, small incision, sutureless, safe, secure, short learning curve, and self-healing, short recovery. Today, up to now in your class, thank you and everybody stay safely.